Thank you for reminding me, because why? I don't want any of this to be lost. Oh, wait a minute. I've got two different computers going on. Hey, so hold on. I got to get this one started again because I got rambling, and when I started rambling, everything went dark. Okay, hold on. Or you have to hear me clear my voice all day long. It's water. I don't know if you can see. Okay, so endocrine. Woo! Diabetes. This is just exciting. I'm holding on. Oh, we also have Victoria is going to give us a student presentation tomorrow as well. All right, let me just snort up snot for you. It sounds so good, and it's recorded so you can listen to it multiple times if you want. Okay, so the objectives for today's lecture are differentiate between the pathophysiology and clinical manifestations of type 1 and type 2 diabetes, identify principles governing the overall management of patients with diabetes, prioritize nursing care for patients experiencing the acute complications of hypoglycemia, prioritize nursing care for patients experiencing the acute complications of diabetic ketoacidosis, prioritize nursing care for patients experiencing the acute complications of hyperglycemic hyperosmolar non-ketotic syndrome, which I prefer HHNS. Describe the management of chronic complications of diabetes, identify the clinical the rest of that we'll do tomorrow, 7, 8, 9, 10, and 11. Okay, fine. I know you're just anxious to get through it. So, all right, so diabetes mellitus. So what is that? A definition. It is actually a group of metabolic diseases characterized by increased levels of glucose in the blood resulting from defects in insulin secretion, insulin action, or both. So you know what? You sit there and you get the definition, you go, why are we even studying diabetes? Who cares? Well, I care personally. And I'll tell you why you should care as well. First of all, diabetes is one of the biggest health care problems and concerns for people living in the United States ever. It literally takes up 25% of the national health care budget, either treating the disease or supplying needed supplies for the disease. It is a huge problem in the United States. Do you know how much the national health care budget is? We're talking trillions of dollars. And this is 25% of the health care budget. So we're talking hundreds of billions of dollars here that is spent on diabetes. Now here's the scary part of it. Are you ready? Are you ready? Okay, let me tell you the scary part about it. The scary part about it is that type 1, which is an autoimmune disease, people are born with it. And then there's type 2 diabetes, which usually develops because of nutrition and metabolic syndrome, which we talked about clear back in the cardiac unit. But type 1, where the pancreas doesn't produce insulin at all, only accounts for 5% of the people that have diabetes mellitus. Can you believe that? So 95% of that hundreds of billions of dollars that is being spent on health care is attributed to type 2 diabetes and can be somewhat controlled or more controlled, not always controlled, but sometimes can, most often can be controlled with diet. that scary? That's why you need to be concerned about it. That's why you need to, dang, good. So it is a dang. It's an outright damn it. Yes, it is. But people don't know this. I don't know if they don't know this or they have just grown up and habitually not eaten well. And therefore develop this. The scary thing too, I'm not finished with the scare tactic, is that because of funding, physical education has greatly been minimized in our children's education. And so therefore, not only that, but the children's sedentary lifestyle where they've become very attached to video games and inside activity, they have a very sedentary lifestyle and they have very poor eating habits. Fast food is just predominates the American diet today. And so many of our children are developing type 2 diabetes under the age of 10. Yeah. So they're going to have lifelong, and more healthcare dollars are going to have to be spent taking care of them. And it's getting out of control. Now, one more scare tactic, and that is this. Because diabetes is such a huge problem within the United States, the healthcare budget, the federal government has allotted that 25% of that budget, or not 25% of it, but has allotted a reimbursement for supplies because, diabetes requires a lot of daily tasks. You have to be measuring your glucose levels, not just one time a day, but 3 or 4, sometimes quite more frequently. More frequently. And so you have those little test strips that you get. The glucometers are free because it's the test strips that cost the money. And one little container of 100 test strips will cost $50 to $60. And you think, well, that ought to last somebody for a month or two. No, not if you're taking your blood sugar or have to monitor it more than once or 2-3 times a day. And for brutal diabetics, a lot of times it's more. Or people that are just learning how to use it. So it's a huge, huge problem within the United States. It's a very, very serious problem because we have got to get the American public's mindset around healthy nutrition. This is preventative care. Can you understand why the shift is happening to preventative care? Because so much money is being spent trying to catch up and to pay for people that could ultimately have delayed or controlled a diet that would have kept them from becoming type 2. So again, it's a huge problem in the United States, and that's why we're spending a whole day of lecture on it. So the complications, and that's not all. We're not just talking about diabetes mellitus here as the sole problem. Diabetes can cause cardiovascular disease, as you saw that one of the main contributors to cardiovascular disease is atherosclerosis. And how does atherosclerosis develop? Through fat starting to embed itself in the lining of the cardiovascular system. Hypertension can also result from diabetes mellitus. Why? Because atherosclerosis narrows the lumens of the cardiovascular system. Kidney failure, why do we know that kidney failure is? Because you know what? Those big old glucose molecules are big old glucose molecules. They do not permeate vessels, the blood vessels, as easily as other molecules do. And so it takes a tremendous amount of fluid to flush the glucose out of the system, what happens here is that when you have, well, we'll get into that a little bit later. It can cause blindness because of the microvasculature of the eye, and then it can also cause cognitive decline because, again, we have the narrowing of the lumens and therefore the decreased amount of volume of blood that gets to the brain, and then you have vascular dementia. So the thing about it is it's a very challenging disease. It's very complex, and it requires daily attention. And historically, a stigma has been attached to diabetes because people think, oh, you're just fat, or, well, if you controlled what you eat, you'd be just fine. That type of thing. And it does add a lot of stress to a person. But here's the thing. Diabetes, and we're talking type 2 diabetes here. Type 1 is genetic. It happens at birth, and it can present anywhere from birth or clear up till a patient is 21 years of age. So type 1 diabetes is not controllable. It cannot be modified. Nothing in your eating can modify it or anything. It's either there or not. But with type 2 diabetes, there's 11 different things that influence the development of type 2 diabetes. So the main thing, of course, is nutrition, which is modifiable, but of those 11 things, there are many that are not modifiable. In fact, and I share this to you, so you will be further amazed. And are you ready? Are you ready? Get a drink of coffee, because you're going to just be amazed at this. I personally am not diabetic. You say to yourself, what? Yeah, I don't understand it either. I should have been diabetic 40 years ago. I've always been fat. And usually that's what we associate with type 2 diabetics, is fat people. I don't have it. And so, there's just something that is genetically makes people more prone to diabetes than other people. And where I am 100%, I don't need 3 criteria to have me do metabolic syndrome. I have all 5, and yet I am not diabetic. Isn't it amazing? So the thing about it is that you can't just look at them and look at people as if they could control it if they want to. They can minimize the risk for it, and proper balanced nutrition is the #1 modifiable factors. But like I said, there are some that are just genetically very prone to it. All right, so we just need to treat them with respect, and teaching them things that they can do to minimize their risk or reverse it. Type 2 diabetes can be reversed. Not reversed, but it can go away. It can be in remission. All right, so there's different types of diabetes. First of all, there's type 1 diabetes. Oh, I lost my screen again. Sorry. I just want to make sure that I get everything that you guys want. Why? Because you're so important to me. All right, so let's talk about these definitions. So type 1 diabetes is when you have increased levels of blood glucose as a result of the pancreas not producing any insulin. Now, again, this is genetic. We consider it an autoimmune disease. We don't really know what causes it. We know that there is a huge genetic component to it. So if there's a family history of it, then more than likely the risk for developing or having a child with diabetes 1, or you developing diabetes 1, is going to be a lot higher, as long as you're under the ages of in your early 20s. Type 2 diabetes, on the other hand, let me just go back and re-stress this, because I can't emphasize this enough, which is what is so amazing to me, is that just 5% of the people that have diabetes have type 1 diabetes. And it has an acute onset. It just comes out. People don't know they have it until they start experiencing some of the signs and symptoms of it. And basically, we don't know if they don't have it when they're very, very young and get into their 20s, anything under 30 puts them at risk for this, is that something is destroying the islet cells in the pancreas, which then no longer produce sufficient insulin or any insulin. And the person ends up with this high level of glucose in the blood. So let's talk about that, just one more thing before we go into type 2 diabetes. And type 1 diabetes, so exactly when we say what is the big deal about insulin and glucose, why do you have to have insulin and glucose? Anybody remember that? You got to have the glucose to make the ATP in the cell. Remember your little Krebs cycle. So I'm looking for comments. So what is the association here? What happens here? Why doesn't the glucose just go by itself, for Pete's sakes? Insulin is the key to get glucose into the cell. Exactly, Amy. I look at it as a little choo-choo train. Yes, I do. So the insulin has to carry the glucose into the cell so that the glucose can be converted into ATP and used for energy in the cell. So you can understand if somebody is hypoglycemic or does not have a lot of glucose in the system, all of a sudden nothing's functioning. They are too weak because there's no energy for anything to work. And so they become unconscious or semi-conscious. Yeah, they do. So it's critical to maintaining the metabolic processes of the body. So if it can't get into the cell, then number one, you're going to have high blood sugars, but two, you're going to have no ATP to make the metabolic processes happen within the body. Okay, so we did a little reminder on that. So with type 2 diabetes, so this is highly associated with obesity. I don't get it. And typically occurs in patients in their 40s or older. And as I said, that is used to be, and perhaps it's well, let me go on and just say, explain something else first. So it can happen in their 40s. Heredity plays a major role, and there is a higher incidence of it in certain ethnic groups. So African Americans, Mexican Americans, American Indians, Native Hawaiians, Pacific Islanders, and Asian Americans are at higher risk. So you have somebody here, and females are at higher risk as well. So you have women, a middle-aged African-American woman that comes in and is complaining of some of the signs and symptoms of diabetes, and you can suspect or ask them if they've ever when the last time they had a blood sugar test was taken, but you definitely want to take that as part of your data collection and assessing what's going on with your patient. Okay, so the thing about it is with type 2 diabetes, there is always going to be some insulin out there. And that's why you can go into remission if you control. We don't understand the pathophysiology of type 2 diabetes, because we don't understand exactly why that insulin is not able to take the glucose into the cells. And why does this happen with obese people? We don't have the answers to that yet. But there is insulin still floating around. The pancreas is doing its job. It's making the insulin. But the insulin is not as effective. It's that the body has become resistant to the insulin, to taking the glucose into the cell. So remember that, because that's going to be important when we talk about some things later, that there's still insulin out there, but it's not getting the glucose into the cell. We don't really understand why, but when they modify their diets, then sometimes it can be reversed and corrected. Shelby, did you have something? No? In and out, in and out. All right, so let's move on. Okay, so let's talk about different types of diabetes as well. There's gestational diabetes. And what happens here is that the extra demands of pregnancy trigger the onset of gestational diabetes. And for whatever reason, I don't know if it's hormonal or whatever it is, but the pregnant woman has a decreased responsiveness to insulin, or doesn't produce enough insulin to meet the increased metabolic demands of the pregnancy. And so after the baby's born, the blood sugar will usually go back to normal. However, this is a huge indicator that this person is at high risk now for developing type 2 diabetes later in life. If the mother with gestational diabetes is overweight, she should be counseled to weight loss and exercise, which will help to decrease the glucose levels in the blood. And we'll talk about that a little bit later as well. Another type of diabetes is called pre-diabetes. And pre-diabetes refers to glucose levels that are above normal, but they do not meet the criteria for diagnosing diabetes. And it usually is a precursor to the onset of type 2 diabetes. And it can be, within a short period of time, or it can go on for years before the person actually develops type 2 diabetes. So the thing about it is that with any kind of diabetes, so what is the regular range for diabetes? Anybody out there? Anybody? Okay, if you were sleeping, let me just repeat the question. What is the normal range for blood glucose out there? You had it in fundamentals. I know you know it. 60 to 100, perfect. So 60 to 100. Pre-diabetes goes from 100 to 125. And then you are diagnosed with diabetes at 126 or more. However, they really don't start treating or prescribing things for treatment until your blood sugar, a fasting blood sugar, can be greater than 150. We're going to talk about that in just a minute as well, so don't write those numbers down or worry about catching them all, because we're going to talk about it in a minute. But just know that anything over 100 is going to be considered pre-diabetes, and then 126 and above is considered being diabetes, being diagnosed with diabetes. Now, even as student nurses, you should have realized by now that there are such things known as secondary diabetes, and you've probably seen this a lot. Maybe you've recognized it or not, but this can develop because of other chronic diseases. Because whenever your body has any kind of disease process going on, it's stressed. And what does stress produce? Steroids, corticosteroids. And so what happens with corticosteroids? Increases glucose. And so you'll see that people that are in the hospital have these sliding scales for insulin, but they're not diabetic. And it's because their body is under stress. And so when the body is under stress and the blood sugar is raised, then we've got to maintain some consistency in the level of blood glucose so the body can function appropriately. So it's secondary diabetes can be the result of surgery. It can be the result of removal of the pancreas if the person has pancreatic cancer. It can be as a result of prolonged drug use, such as steroids or thiazide diuretics, or a thyroid hormone. It can, let's see, what else? Oh, and it can also be a result of taking TPN. In fact, in some hospitals, they'll have a protocol that if you are administering TPN, then you need to monitor the blood sugar levels while the person is on TPN. So hyperalimentation nutrition is going to cause secondary diabetes. And then when you stop that, when you stop the steroids, when you stop the what the heck? You know what I'm talking about. Anyway, somebody, hydrochlorothiazide. It doesn't sound right to me. I don't know. Anyway, so certain drugs such as TPN can cause that as well. Now there is another, I'm using the wrong mouse on the wrong computer. Another definition that we want to look at, you don't have to memorize this. Oh, it's gone. Is there one still in here? No. Okay, so this definition right here, this latent autoimmune diabetes in adults. Latent autoimmune diabetes in adults. It's called LAUDA. And it's a subcategory of type 1, but it may not require insulin. It is a brand new term that is being used when in association with diabetes. And so I'm putting it out there so that you may become familiar with that and just recognize that it has to do with diabetes. We're not really going to discuss it today because why? It's not an objective. So dang it, we are not going to discuss it. But I wanted you to be familiar with that it is a subcategory of type 1. And again, it's an autoimmune. We talked about that earlier for type 1 diabetes. But usually type 1s are dependent on a synthetic insulin or that's brought into the body. But with the latent autoimmune disease, you don't necessarily have to. Okay, let's see where we are. Okay, so here, let's talk about these clinical manifestations of type 1. And I have to tell you that this is according to any study for an exam. You'll want to know this slide. So there are 3 P's. They call it the 3 P's. And interestingly enough, it has to do with P. And the 3 P's are the classic signs of diabetes and type 1 diabetes. So urinating often is called polyuria. Now, you need to look at these terms that they are synonymous with each other. Well, of course, because it's a definition. It's a stupid statement. Go ahead and just chalk that one up. The other one up for Vicky's teaching. Stupid statement. Okay, so polydipsia, feeling very, very thirsty. And this is a thing that is interesting about this. So with the person drinking huge amounts of water, they just have this thirst. Then they're going to start peeing a lot as well, taking off the fluid. Today, not yet. The kidneys are not damaged yet, but could eventually if the diabetes goes uncontrolled. But because you're taking in a large amount of fluid, the kidneys are going to process a lot amount of fluid, and they're going to have a lot of urination that is associated with it. But here's something interesting too with diabetes type 1, you're feeling very, very hungry all the time. And that's called polyphagia. And it's interesting, you lose weight even though you are eating a lot more than you ever would. Interesting. You do have extreme fatigue. They are going to have cuts and bruises that are very slow to heal. There will be ketones in the urine because we got to have something for energy. So if we're not going to burn any carbs, we've got to burn some keto. We're going to have ketones. We're going to burn fat, which a byproduct of burning fat for energy is ketones, which go into the blood. And because they go in the blood, then they're going to go through the kidneys. And some of those ketones are going to be excreted through the kidneys, not all. Because when a person accumulates a lot of ketones in the blood, then it turns the blood acidic. And that's where you get your ketone acidosis from. And then the weight loss, we talked about that already. Okay, so the difference is that with type 2 diabetes, we are going to have, are we going to have polyuria? Could be, may not be, don't know, could or could not. But they will have polydipsia. And so they're going to be feeling very, very, very thirsty. They are going to have fatigue. They're going to have blurry vision, cuts and bruises that are slow to heal, typically overweight. They may have tingling, pain, and numbness in the hands and feet for neuropathy because the glucose molecules are my fly swatter. I've got a frickin' fly in here that's been bugging me all morning. And for just a minute, he was here, and now he's gone again. Okay, sorry, I was distracted. So anyway, this is neuropathy because the glucose molecules, again, are just kind of, they're large. They aren't permeating or through the blood vessels. And so even though, you get this, the vasculature gets very small when you're feeding nerves, or supplying nerves with oxygen. Oh, hold on, people, hold on. Oh, missed it. Sorry. So what else? So then we're not feeding the nerve with the blood. The glucose is not letting the blood get out and feed the tissue. All right, so let's look at a definition of diagnosis for diabetes, and this is a diagnosis. So you have to meet this criteria in otherwise to be diagnosed. So normal blood glucose levels are 60 to 100 milligrams per deciliter. So you will be diagnosed with diabetes if you have a fasting blood glucose. So this is why they want you fasting for a minimum of 8 hours. But if you have a fasting blood glucose of greater than 126, then you'll be diagnosed with diabetes. So you can also have symptoms of diabetes. So you're having your polydipsia and your polyphagia and your 3Ps. You've got your symptoms of diabetes going on there. Plus, in your blood plasma, your glucose levels are going to be greater than 200. And then we also have one of those OGTT tests where you go in and you've been fasting for 2 hours and you drink that little special cocktail of milky stuff for you. They do a glucose test on you. And if you have, comes back with a greater than 200 milligrams per deciliter, you are going to be diagnosed with diabetes. And then if you have glycohemoglobin, or this is your hemoglobin A1C, then if it's greater than or equal to 6.5%, they are going to diagnose you with diabetes. You're going to want to know this slide. Okay, so that was your slide for diabetes, but let's look at pre-diabetes. So again, normal blood glucose level is 60 to 100, but if you're fasting for 8 hours, if you have a glucose level of anything between 100 and 125, or if you have an oral glucose tolerance test of 140 to 199, or if you have an A1C between 5.5 and 6%. So I think we're going to take a little break here before we start this next section, because this next section talks about the 5 areas of therapeutic treatment management that we give to people that have diabetes. So let's see, it is 10:32. Let's come back at 10:45 and we'll begin this section of this titillating lecture. Okay, we're back. So anytime somebody has been diagnosed with diabetes, they usually have to go to what we call a boot camp. Yes, they do. Back in Oklahoma, there was a clinic, and on certain days they would teach foot care, and other days they teach self-monitoring. There's all these different things that a person that is newly diagnosed has to learn, because it's a whole new world out there. But the basis or the foundation for any type of management of a person that has been diagnosed with diabetes are these 5 areas. It includes 5 different categories. So it includes nutritional management, of course, but it also includes exercise, blood glucose monitoring, and making sure that they have the capabilities to interpret their data that they collect. Any pharmacologic therapy, if they have to become dependent on insulin injections, how to do that. And then, of course, patient education about their disease and how to do several of these different new skills that they have to learn. So we're going to examine each one of those areas and learn what we have to know about the goals for each of these areas of management. So again, let's begin with the nutritional management. So this is something that, and I'm sorry that this blocks it, you'll have to get it off the module on Canvas, but the number 1 goal for nutritional management is to prevent wide fluctuations of blood glucose levels in the blood. Well, that was redundant, wasn't it? Blood glucose levels in the blood? Yeah, a little bit. Let's say it one more time. Blood and blood. Okay, but we also want to achieve optimal lipid levels. We want to keep our cholesterol, our triglycerides in check. But while we do all of this, we have to provide adequate calories for maintaining a reasonable weight and fostering normal growth and development. So we don't just want to starve these people to death. We do want to make sure that they learn to develop a lifestyle of nutrition balance that will afford the accomplishment of all of these goals. Do I think you need to know this slide? Yes, I do. As a matter of fact, I do. All right. Other goals of nutritional management include, and I don't know why these pictures relocate when they get onto Canvas, they just do. But we want to prevent, delay, or treat nutrition. Wait a minute, I've kind of lost my place here. And some of the related complications that can occur if you have imbalanced nutrition. We want to improve their health. We want to have them learn to eat at consistent times in conjunction with their self-administration of insulin. We want them to learn to adjust their insulin doses according to the amount of food that they ingest. So we adjust pre-meal insulin doses as needed. We can delay pre-meal insulin if the trays don't come up onto the floor on time. And we want to administer extra insulin for snacks, which are not part of the usual meal plan. So do you think a person that is newly diagnosed with diabetes needs to be monitored as far as food intake? I mean, how many of you have had somebody in the hospital before and you go to visit and you bring them McDonald's or you bring them food because they hate the hospital food? Yeah. Do you think that that's going to affect the diabetic's blood sugar? Yes, it is. Yes, it is. So we just have to really monitor closely somebody that's been newly diagnosed because they haven't learned the consequences of not adhering to a regime or not managing their nutritional intake adequately. So let's look at the caloric requirements. Now, the thing about a deal, sometimes I just lose it. So one of the things about nutritional intake is that we have to maintain a certain amount of calories for our bodies to function. So we want the body to function at an ideal weight. Hold on. Oh, that's Renee. Just a minute. It could be something related to this class. Let me mute this just a minute. I am so sorry about that. That was Renee, and she needed something for the PN ones. Sorry, I'm just in such demand. Okay, so we're talking about caloric requirements. Oh, okay. So what used to happen with the American Diabetic Association diet was that they would just assign people calories. So they would have a 2,000 ADA diet, and you would document that if that was what your patient was on. But somebody for me that was newly diagnosed with diabetes, I would have to, they would strongly encourage me to lose weight. And so, whereas usually for a person to maintain an ideal weight, they take approximately 2,000 calories a day. But for me, no, they probably slap that down to 1,800 or even 1,600 ADA diet so that I would lose weight. So we want to calculate what the caloric requirements for maintenance of an ideal weight. Well, I'm not at an ideal weight. Surprise. And so they would want to calculate a lesser number of calories for me. For young type 1 diabetics, they need to have their calories increased a little bit because they're going to be growing and developing, and they require a higher amount of calories per day to accommodate that. For type 2 obese patients, then they should usually have 500 to 1,000 fewer calories for a weight loss of 1 to 2 pounds per week. So again, whereas usually a normal adult would take 200, then they may want to do a 1,500 calorie diet. Of course, when you're saying 1,000, then I don't know why I have 1,000. I can't think you'd be down to 1,000 or 1,200 calorie diet. That's pretty extreme for somebody that is newly diagnosed. And you literally have to work with the patient so that they can be consistent. If you put somebody that's used to eating 2,500 to 3,000 calories a day down to a 1,200 calorie diet, do you think they're going to stick with it? No, they won't. So you manage this, you work with them, these are your goals. But one thing you need to recognize that a loss of 7% of a person's body weight can decrease the need for insulin or medication, oral medication, to reduce glucose levels. And it will improve the glucose levels in the blood. So 7% is huge, 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 huge. So, one thing I was thinking about when I was talking, because my mind goes all over the place, but there is a certification you can get as an RN, as a diabetic educator. And you have to have worked with diabetes education at a level, either in the hospital or in a doctor's office, an endocrinologist's office, for a couple of years before you can get your certification. But there is so much teaching and managing that has to go on for newly diagnosed diabetic patients that there is a certification for that for RNs. Okay, so whatever caloric value you are given to achieve during a day, we start with calories because that is dependent on your weight and what your ideal weight, any weight loss that you have to achieve. So we determine the calories first, but then we break down the distribution of those calories. So for carbohydrates, we do not want 45%, more than 45% of our intake to be carbohydrates. So we want 45% to be carbs, and it should be complex carbohydrates. We want 15 to 20% of our intake to be protein. And then we want 20 to 35% to be healthy fats. Now, for fiber, another thing that we look at, we usually just want to consume the same amount that a person on a normal, regular diet would consume in a day. So high fiber, there isn't much contribution as far as to whether somebody is diabetic or not. It is the fats, the proteins, and the carbohydrates that we want to pay attention to. And again, 45% needs to be carbs, 15 to 20% protein, and 20 to 35% fats. And do you need to know that slide? Yes, you do. High five. Let's go on. All right, so how do we achieve that? How do we achieve the caloric intake that we need and manage our carbs, proteins, and our macronutrients to meet our goals and manage our nutrition? And there's different ways to do that. And so they have what they call classification systems. So for the first thing that we want to look at is exchange lists. Is anybody familiar with what an exchange list is? Okay, let me ask this. Does anybody care? I know you did. Well, these an exchange list, oh my gosh, this started way, way back. I first heard about them in the 80s with Weight Watchers. But food exchange list is an easy way to create a meal plan because it gives you a variety of choices while you are, and which makes sure that the consumption of carbohydrates is controlled. Usually meal plans are devised by the patient with a nutritionalist that specify the number of servings the patient can have from an exchange list. So what we're basically talking about here, that if the doctor orders that the patient can have 2 carbohydrate exchanges, the patient will have this list of foods that are defined as being a carbohydrate exchange. So they will have, for example, if you were to have 15 grams of carbs, you're allowed to have 15 grams of carb. That's your prescription. Then you can either choose a piece of white bread for that. But if you don't like white bread, then instead you can have a cup of milk for that. And if you don't like milk, then you can choose an apple for that. Whatever's going to provide you the same carbohydrate amounts is put onto one list. And you can exchange, if the doctor, you can exchange by preference or choice what you want to eat. So anything on that list, you can exchange one with the other and still meet the balance and you need while managing the amount of carbs that you have in your body. So that is what an exchange list is. And then the federal government became so concerned about the malnutrition in the United States for its citizens, it put out a website called My Plate, which basically, and it still exists today, but it's not called My Plate. Hold on just a minute. I don't think I have that available. I'm looking for it. No, I don't have it available. Okay, so myplate.gov, I think you can type that in and it will still be there. It gives you all the wonderful things about balanced nutrition. If you're a young mother or you have kids that all they eat is cold cereal, then you can sit there and go on this site and it gives you all kinds of information about the calories, that the number of calories your children should be intaking at their specific age. They have gluten-free, they have diabetic diet information. They have so much information on that, trying to educate the patient about, the public about nutrition. And they gave recommendations for meal planning. And then another type of classification system that can be used is this plate right here, is that they break it down. So any 9-inch plate here, it's portion control. Half of it needs to be vegetables, a fourth of it needs to be a starch or bread, and then a fourth of it needs to be meat or some kind of protein. So that's another method that you can use to do that. Another method that is used for meal choice or food choice is the glycemic index. So what the glycemic index is all about is that each food has a ranking of carbohydrates, and it ranks a food from 0 to 100. According to the extent that the food raises the blood glucose level in the blood after eating. So this is all evidence-based, and it's recommended for the management of diabetes mellitus. The thing about it is that today, most evidence-based suggests that diabetics use a glycemic index food choice or method as part of their nutritional management. So anytime you have food that is greater than 55, then it is considered to have a high glycemic index, and we want to keep the index level somewhere less than 55, but greater than 10. Less than 10 is low. And again, this requires a certain amount of education because a food can change its glycemic load depending on how you prepare it. For example, raw carrots have a glycemic load of 16, I think. But if you cook those carrots, or not cook them, but steam them, then the glycemic load goes up to 60 because much of the water has come out of those carrots. They become much more dense and full of sugar. So you can understand why the difference is going to occur in your blood glucose levels. So low GI carbs are considered to be less than 55. And, you know, eating foods that are less than 55 is considered to be one of the secrets to having long-term good health, which reduces the development of type 2 diabetes. And it can also be one of the keys to losing weight if you opt to do this type of method of managing your food. High GI rankings, and we're talking GI is glycemic index. These foods are rapidly digested, and they're absorbed and metabolized and result in huge variations and fluctuations in a person's glucose level. Okay, so here's some examples of this. And I just put up, you don't have to know this, so don't memorize it, but you have to, I want you to read through these because these are examples of low GI food, glycemic index foods, 55 or less. Or I want you to also read this, those foods that have high glycemic index levels, which is 70 or more. Remember, they only go to 100. But you need to be able to recognize what's good for you, what isn't good for you. Now, one of the types or methods that can be used, and which is frequently used today as well, is carb counting. And this is a method for managing nutrition for a diabetic patient. So usually you count the carbs that are included in a piece of bread. And a lot of times you can find a piece of bread, but you can find the carb count on any food that you ingest or any label food with a food label. And you need to recognize that 12 to 15 grams of carb is going to require 1 unit of rapid acting insulin. So you have to be able, and this takes years to develop depending on your age, for you to learn to be able to look at food, recognize how many carbs you're looking at, and that will help figure out how much insulin you need to counteract those carbs. Okay, so here's a little example of a meal that is using the carbohydrate carb counting. What did I just say? I don't know. Did that even make sense? No, I don't believe it did. Okay, so this is an example of carb counting. Yeah, simple as that, of how someone counts carbs. And you can look at that and just peruse it later to learn that. But again, how does this change your life? How much do you think about all those chips and cold cereal and all that stuff that you're eating to stay awake in my lectures? So do you even think about any of that? No, it just keeps you awake. That's your primary goal here. Well, as a diabetic, you can't just blow it off. Everything that goes into your mouth affects your blood glucose level according to your body's capability of producing insulin or taking insulin into that cell. And so you can't just blow it off that you had a big Thanksgiving dinner or that you ate, 4 bags of chips to get through this dang lecture today because it's so exciting. You can't blow it off. You have to recognize what you need to. Aslan said she'd die. I know. I had a couple of chocolate bars today. Have you? So anyway, all right. So, but when we're talking about nutrition, we don't just talk about food because there's a lot of things that Americans ingest, in fact, people all over the world ingest that are associated with blood glucose levels. So we have to address those in our nutritional management as well. And alcohol is one of those things that we need to consider because why? Because Americans like to drink. It's a fact, Jack. Now, I know that you think that, well, it's not that you think it, it's a known fact that ethanol is a sugar, isn't it? So you think that alcohol is going to cause hyperglycemia. Am I right? Who believes that? No, is Aslan the only one still awake? It's okay. There's no judgment here. I'll just cry myself to sleep later today after I get my COVID testing. No, alcohol can actually drop blood glucose levels because alcohol blocks the production of glucose in the liver. So do you remember that, the liver, that's one of the functions is it does glyconeogenesis, is it produces glucose. And once the liver store of glucose are all used up, a person that's had a lot of alcohol to drink can't make more right away. And so what's going to happen is it's going to lead to dangerously low glucose levels. So alcohol can cause hypoglycemia shortly after drinking and up to 24 hours after drinking. So if you're going to drink alcohol and you're diabetic, you better check your blood glucose before you take that big old shot. Shots aren't very big, but it is when you're considering glucose levels here. And then if you continue to drink, you need to continuously check your glucose levels. But the thing about it is that it can also cause a person that's going to bed, let's say you get drunk, really drunk, really drunk, and you're getting ready to go to bed. Sometimes a drunk person will pass out. I know this is news to all of you. It's amazing. But they'll pass out. Do you think they're going to stop and take their blood glucose level? Probably not. So you need to have not only a designated driver when you drink, you need to have a designated glucose taker. Because you need to have a minimum of 140 milligrams per deciliter of glucose in the blood before you go to sleep. Why? Because you may not wake up. So just be aware of that. So let's go back to this for just a minute. First of all, it may interact. Sorry. This is not to say that a diabetic can never drink alcohol. You can drink alcohol, you just have to drink in moderation. And you have to recognize what is happening so that you're consistently, if you are drinking more than a glass of wine or something like that, you do need to be taking your glucose levels so to make sure that you don't become hypoglycemic. And you want to make sure that, I think this is a whole different slide. We'll have to see. You want to check that to make sure that you have 140 before you go to sleep for the night, so that you can maintain the energy needed for the metabolic process of the body throughout the night. Okay, but alcohol can lead to excessive weight gain. Have you ever seen those beer bellies? Yeah, we got those in Oklahoma a lot. And we got them with those wife beater t-shirts. Yeah, they're not t-shirts, they're, what are they called? Oh my gosh, I'm losing my mind, people. I'm losing my mind right here in front of you. I'm losing my mind. Tank tops. Thank you, Megan Short. All right, so yeah, those are very attractive, those beer bellies. Yeah, they really are. Especially if someone's drinking a beer right in front of you and you're getting to see it all. Yeah, okay. So anyway, it can cause people to gain weight, and it can cause them to have hyperlipidemia, high cholesterol levels, high triglyceride levels. If they're using mixed drinks, then it can raise the blood sugar levels in the body. But don't forget that danger of hypoglycemia, because the person, if they're drank, may impair their ability, if they get drunk, impair their ability to recognize signs and symptoms that they're having related to hypoglycemia. Because I didn't have a slide on it. All right, sweeteners. So how do sweeteners affect a diabetic? First of all, it doesn't matter. Once again, just like alcohol, moderation with the amount of sweeteners you use can be encouraged, but we need to recognize what's happening with them too, so that we can avoid potential adverse effects. So there's two different kinds of sweeteners. There's nutritive and there's non-nutritive. So nutritive do contain calories, which is similar to sugar and sucrose, but it causes less elevation of blood sugar than the non-nutritive. And you'll see used often in what they call sugar-free foods. Now, non-nutritive sweeteners don't have any calories at all. And so these are your things like saccharin and NutraSweet and Splenda and Truvia and Stevia, but they don't produce any elevation in the blood glucose level. So you have to look at yourself. You have to decide which one you're going to use if you are diabetic. And if you want to avoid the adverse effects, you want to use these in moderation. Okay, one thing that anybody needs to be aware of is misleading food labeling. And this is especially true for diabetics, but really all of us need to be very aware of what food labeling is and what it says. And we need to start reading more and more food labels so that we know what we're taking in. So a lot of times a food label is labeled sugar-free or sugarless. But you got to remember, it still has calories. So if you eat sugar-free food all day long and think that it has no calories, you're absolutely wrong, and no adverse effects. And you may not understand why you can't lose weight if you're eating lots and lots and lots of sugar-free candy or something like that. Why aren't you losing weight? Well, you still got calories there that you're not using for anything. So keep that in mind. Also, foods are sometimes labeled as fat-free, but again, they can have a high calorie count, but you have to also look at the trans fat content because that can be misleading. And then health foods often have saturated vegetable fats in them, but they may also have honey and brown sugar and corn syrup, which will add to your glucose levels as well. So again, you have people that are newly diagnosed with diabetes have to know so much about nutrition because everything they put in their mouth will affect their glucose levels, and they just need to optimize their ingestion of nutritional food so that they can meet those goals. And what was the goal of nutritional management? First slide, after the 5 areas we were going to talk about. To reduce wide fluctuations of blood sugar in the bloodstream, to optimize lipidemia levels in the blood. What else? There you go. I see it, Hannah. Hannah, I see you coming. Here we go. Mapu says provide adequate calories. Perfect. You guys are getting it. You're getting it. So yes, you can meet the calories that you need to intake with some of this stuff, but are you going to have the other nutritional things? Is it going to minimize your sugar content? All right. The next category that we're going to talk about is exercise. And this to me was very, very interesting. May not be to you, but to me it was very, very interesting. Why? Because I hate exercise. But this is something that just blew me away when I learned this. First of all, let's just look at some of the guidelines here. Exercise should be done daily, and it does lower glucose levels. And let me tell you why. This is what is amazing to me. And this is why it is a category in the management of diabetes that needs to be stressed to the patients. And that is, when you're exercising, and it doesn't have to be powerlifting or jogging 100 miles or anything like this. This is walking across the room. This is doing anything. This is getting your steps in, whatever number of steps you're at, so that you want to achieve. This is with any kind of movement at all. What happens here, when you begin the exercise, and when the muscles begin to contract and work against the vasculature and with the cells, the blood getting into the cells, the blood getting into the cell. Oh my gosh. The cells that are in the blood take up the glucose levels. They don't have to have insulin to take the glucose into the cells. Let me repeat that to make sure you understand it, because to me, it is just amazing. And that is, exercise is so important for diabetics because when the muscles begin to contract, then glucose can get into those cells and provide the ATP without the need of insulin to get into the cells. Isn't that amazing? To me, it's amazing. So this is how exercise can help lower the glucose levels in the blood, and how it can help reduce your hemoglobin A1C. Yeah. And we're not looking at high packed 2 hour a day exercise. We're talking about walking 20 minutes a day, just, 5 days a week, just 150 minutes of exercise a week. That was not multiplied correctly, but 30 minutes a day for 5 days a week, 150 minutes of exercise a week. Yeah, if you do it, but you got to get up and do it. And so you do want to get up and walk, and you want to do it for 20 minutes at a time. And during that time, now that is short lived. So when I say 20 minutes, I mean, it's just for a short time that the glucose can get into those cells while they're contracting without the need for insulin for a short period of time. So this is why we want to break it down to 20-minute, 30-minute segments. But again, if we would just do that as a nation, think of the amount of health dollars we could save and devote to some other need. Little things. I know. So physical activity can lower blood glucose levels for up to 24 hours or more after a workout by making the body more sensitive to insulin. And exercise should be done daily at the same time. But for those overachievers who go to Vasa after taking a test at nursing school, then there's some things that you need to recognize, because the increased need for glucose during long exercise periods, so exercises periods that last more than 2 hours or last for extended period of time, depending on the acuteness or the difficulty of the workout, then we need to manage that. We need to pay a little bit of attention to that. So again, just like with consuming alcohol, you need to recognize that your body needs to fluctuate or not fluctuate in great amounts during exercise. So first of all, before we begin exercise programs, when you're again looking like a hard term workout here, and anything over 20 minutes is hard term to me, 20 or 30 minutes. Yeah, that's hard term. So anytime you're going to do a full-on workout that lasts for a significant period of time, you need to take your blood sugar, know what it is, and get yourself a snack if you need it to begin the exercise. But then you need to check your exercise during that workout, because you're going to be using up your blood glucose, and we don't want to get so low that we can't function. So we need to check it before we begin. We need to check it during it. And if we have hypoglycemia, we need to get a snack. And then we need to check it again afterwards and get a snack if we need that as well. And if you have hyperglycemia, that means you got a lot of glucose. You're thinking, ooh, I'll work this off with this exercise level. But if you have ketones in the urine, then we need to postpone the exercise until the blood glucose is back to its normal range. And the urine needs to be free of ketones. Okay, got that? Do you think you need to know this slide? Yes, you do. right, so exercise precautions. First of all, check the blood glucose before beginning. I told you that. If your blood glucose is less than 100, then you need to take 15 to 20 grams of a carbohydrate. And like I said, that can be a piece of bread, it can be an apple, it can be something. You need to make it a complex carb because it levels a little bit. There's simple carbs that can raise the blood sugar up and then it comes right back down again. Like orange juice, up and then down. Piece of candy, up and then down. But we want a complex carb because it raises the blood sugar and evens it out. It just plateaus it for a little bit before it goes down. So it lasts a little bit longer, and that's why we want it to be a complex carbohydrate. 15 grams to 20 grams of it before you begin. And then 15 minutes after you're doing your, hard term workout, then if you check your blood glucose again and it's less than 100, then you need to take another carb. Okay, and we repeat this every 15 minutes until the blood glucose is at least 100 milligrams per deciliter. Okay. Other things that you want to consider during exercise that you use proper footwear and, if appropriate, other protective equipment. One of the things that we'll discuss a little bit later is foot care, because neuropathy can set in very quickly with a diabetic. We want to inspect the feet after the exercise to make sure there's no injuries going on there. Avoid exercise during periods of poor metabolic control, which is basically what is happening up here when, or on the previous slide, when the person had hyperglycemia and had ketones in the urine. That's poor metabolic control. Why? Because they're in metabolic acidosis, because they got ketones in the blood, which is causing it to be acidic. Okay, and avoid extreme exercise in extreme hot or cold. Okay, so the next thing that we're going to look at is glucose monitoring. If you will look at your little categories of levels of management that we saw in those 5 circles when we started our lecture, we are looking at glucose monitoring here. So I cannot tell you, geez, I wish I had been the one to invented it, what self-monitoring meant to people that had diabetes. Can you believe that? How would you love to have diabetes before you were allowed to self-monitor with your own little glucometer? You have to go to the doctors, get it done, determine what to make. It was impossible. These people were really sick. Why? Because they had these huge fluctuations in blood sugars. So self-monitoring, was a kiss directly from God, because these people now were able to be more independent. But there's certain things, and this is again new education, patient education, that you have to give to your patients, because they don't know about self-monitoring. They're not really sure how to do it. So you teach them how to do it, but now they've got to learn to interpret the data. So there's certain functionalities of the patient that are going to be required to allow them to self-monitor. I hope you understood that correctly. There are some people that have dementia. Maybe they can still take their own glucose level just fine, but they don't know what to do with the information. And so it's not just about OT and dexterity of the fingers. It also has to do with cognitive function. So the patient that self-monitors has to have the ability to see where to insert the strip in the glucometer, where to read the fine print. They need to be able to stick themselves and get it on that teeny tiny strip And then they need to be able to interpret the results. And not everybody, you remember, a lot of people will develop type 2 diabetes later in life. Usually it begins in their 40s, but some don't develop it until they're in their 60s or 70s. So they have to have the ability to self-monitor it, or they're going to have someone help them do it. And there has to be a willingness on the patient to they want to have the desire to self-monitor so that they can maintain that independence. There have been a lot of inventions in the last few years related to diabetes and how information can be transmitted to the doctor's office. But again, information has to be received by the patient about what to do with that value when they get a lab value that's either high or low. All right. Benefits of self-monitoring. Oh, sorry, Dakota. Vasa is your second home. I'm not mocking Vasa or people that do hard workouts. I wish I had your drive. I don't. But I'm proud of you. Damn it. Then when you're 40 years later sitting in front of a computer, you won't have to give this lecture. All right. The benefits of self-monitoring. First of all, you can what we want to document is glucose levels at a very specific point in time. So because, for example, we need to know what it is before a person eats their meal to determine if we need to give them more or less or hold it, or when we need to bring them the food. The values will guide the patient and the healthcare team in understanding what affects the blood glucose levels for the patient. It helps the healthcare team recommend or adjust any therapeutic schedules that have been developed. And it aids in preventing or delaying the onset of complications. So it's really, 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 really important that this self-monitoring was invented to improve their quality of life. People that have new diabetes can be as high functioning level as they possibly can. So they have, like I said, different inventions that have come out now. They have continuous glucose monitoring, which can either be via a catheter that is placed under the skin, and it transmits data to a pager, and then it alarms if the glucose levels are too high or too low. And there are certain of these little mechanisms that can be even linked to a pump, an internal pump. Now, with the catheter itself, that is just taking the level of blood sugar in the blood, then the catheter will need to be changed every 3 to 7 days, because depending on the manufacturer's recommendation, because of the high risk for infection with hyperglycemia. So, but internal pumps, I'm not real sure how that works. If they are continuously there, or they have to be replaced annually or biannually. I'm not real sure about that. Okay, so another thing that needs to be monitored for people that have diabetes is testing the urine for ketones. Again, let's go back a little bit, pathophysiology, figure out what's going on. So the glucose is floating around in the body, can't get inside the cells to assist in the creation of ATP. So what happens is that we've got to have some form of energy there. So we are going to start burning fat. And then when fat is metabolized, it turns into ketones. Ketones are now floating around in the urine. Ketones are floating around in the blood, and it turns the blood very acidic. And so you will usually see ketones starting to develop in the blood when glucose levels reach around 240 milligrams per deciliter. So if you have a finger stick that for a type 1 diabetic, that glucose level is above 240, then you can highly suspect that there are going to be ketones in the blood, which is going to make the person's blood very acidic, which is going to result in ketone acidosis. A person that is sick or vomiting can become dehydrated. And again, we can see ketones develop here. So we need to be very, very, very cautious about people that are sick or have high glucose levels, because we know that they will start developing ketones in the blood. Some of them will be excreted through the urine, and we can use a dipstick. If we suspect you pull the glucose level of higher than 240, then you'll want to get a dipstick and test the urine for ketones. So insulin therapy, I'm not going to spend a lot of time on this because you're going to get this where and farm. So I'm not going to spend a lot of time on this, but I did want you to be aware that there are many different kinds of insulin. And this is all worked out with your endocrinologist so that they can determine what you need and how you need it. Just be aware that there's rapid acting, short acting, intermediate acting, very long acting. And then there's premixed type of insulins as well. And you're going to learn all about that in pharmacology, which again, so glad I don't have to worry about that one. Okay. Also know that there are certain oral medications that are given to type 2 diabetics with uncontrolled blood sugars, despite the fact that they're exercising more and they've modified their diet a little bit more, they still have high blood sugar levels. So oral anti-diabetic agents will stimulate the pancreas to release more insulin and to make the tissues more sensitive to insulin. But if the oral agents are not fully effective, then with type 2 diabetics, they can have insulin supplementation as well. So you can supplement with insulin injections if a type 2 diabetics oral medications are not helping to control the blood sugar to the level that we want it to be. All right, so when we're looking at monitoring glucose levels and ketones, then basically, what does preprandial mean? Everybody's gone to lunch. All this talk about food has made everybody go to lunch. Preprandial is before eating. So preprandial, thank you, Hannah, for staying awake. Before eating. So preprandial goal for diabetics is that we want their blood sugar level to be between 80 and 130. For children or geriatric patients, it can be 100 to 150, but this is before eating. So after eating, we want their blood sugar to be less than 180. So typically, this is what the sliding scale is used for, is to determine, okay, here that we've just taken their blood sugar, it is, I don't know, 120 or whatever. We're going to determine how much food that they're going to eat for lunch. They're on a diabetic diet, so we know how many calories they're going to need. So the doctor's going to figure out what their sliding scale is going to be. So we will give them enough insulin to counteract the intake of food before, for their meal, and that will be administered prior to the meal. And then they eat their meal, and then when we want to take their blood glucose level again and make sure that it's 100, under 180. So you kind of really got to know what you're doing, don't you? But we want to make sure too, what if you give them, you figure out, you go to your sliding scale, you pull the amount of insulin that the doctor has suggested, regular insulin, so it's going to be acting within 15 minutes or so. And then we're going to go collect the tray after the meal, and we saw that they weren't very hungry, so they didn't eat anything. So now we've given them all this insulin, and they haven't counteracted it with any intake. So now we need to take their glucose level again to make sure that they're not hypoglycemic, because we got to fix that. We're, again, trying to avoid these large fluctuations because it can result in some trouble. And then, again, when we're talking about A1Cs, which basically the average of your glucose over the last 3 months, we want it to be less than or equal to 7%. Now, there's two things, and you know what? I don't know about you, but it's 11:45. Let's take a break. Okay, so during this break, get yourself something to eat. And we'll just skip lunch and just keep going so that you guys can get done here a little bit earlier. So take a break. We're going to talk about the dawn phenomenon and this emoji effect when we get back. But get yourself a little something to eat. Okay. Okay. See you in at 5 to 12. All right. Well, we're back. Yeah, we are. Okay, so there's two conditions that results in hyperglycemia, known as the dawn phenomenon and the emoji effect. So basically, we all have high blood sugars in the morning, even though we're sleeping all night long. And we don't have any food intake. And we're not talking hyperglycemia, but we have normal blood sugars. And you're going, how can that happen? Because I haven't eaten all night long. And that is because in the normal body, there will be counter-regulatory mechanisms going off where either the liver will produce some glycogen because we haven't eaten all night long, and so we notice that there's low blood sugar, so the body will produce some glycogen, and then blood sugars will rise. However, the dawn effect is where basically that happens, is that the blood sugar has been going down, down, down all night long because we're not taking in any intake. And then around 3 o'clock in the morning, the body recognizes this and produces some glycogen, and then the blood sugars will start to rise again. So that is called the dawn phenomenon. And it's not the result of anything. It's just a result of a hormone in fluctuation during the night, and then the release of stored glucose from the liver. However, the emoji effect is a little bit different. And the Samoji effect is usually because a person has missed taking their insulin at night. That's not true. They missed taking a snack. They've either missed eating or they've missed having a bedtime snack to help get them through the night. And so this is where the person's blood glucose level drops so low that the body responds by, again, these counter-regulatory hormones, which then cause the rebound, the hyperglycemia that we look at in the morning. So what I'm trying, if you're trying to differentiate these two phenomenons by hyperglycemia in the morning, even for diabetics, then the dawn phenomenon to me is just like any normal thing that would happen with a normal body, is that you have these regulatory hormones going back and forth all night long, maintaining a regular blood glucose level. This is about the point of the lecture where I really start thinking I've got to quit because it's just, I'm losing it. Okay, so then the Samoji effect is that it's because the person has missed their snack, missed eating that night before dinner, and they want Samo food. I'm sorry. It's the best I could do. You figure out what your little trick in your brain wants to be as far as how you're going to differentiate between those two. But remember, it's just because of a misstep or you've taken too much insulin and the blood sugar drops so low that you have regulatory hormones which will cause the liver to release some glucagon resulting in your higher glycemic levels in the morning. Okay, so now we got to look at some of the complications of hypoglycemia. And this again is where we have too low the sugar in the blood. There's too much insulin for the blood glucose load and not enough food, not enough excessive exercise to get rid of those excess glucose molecules in the blood. So just recognize that a person with hypoglycemia, it can occur any time of day or night, just depending on what the person does. This is a diagnosis of hypoglycemia occurs when the glucose levels are less than 70 milligrams per deciliter. And the thing about it is, and why we have to recognize these signs and symptoms is, or why we need to recognize signs and symptoms of hypoglycemia is that because extreme hypoglycemia can be fatal. That would be hypoglycemic encephalopathy, where the brain is not able to use the carbohydrates that are available to give it its energy, to meet its energy needs. Remember, the only fuel for the brain is carbs or glucose. So we got to feed it. And if there is hypoglycemia there, then it's going to affect the brain. So the brain requires a continuous supply of glucose for fuel, and if you're hypoglycemic, there's a high risk of developing hypoglycemic encephalopathy. So what are some of the causes of this? It can be that a person has skipped a meal. It can be that they've exercised more than usual, or it can be that they've administered too much insulin. So if insulin peaks without the ingestion of food, the patient is going to experience some kind of hypoglycemia. And if the person complains of not feeling right, trust me, diabetics are so in tune with their bodies. They know exactly if they've had too much sugar, if they have too low of sugar. They just know that they're not feeling right. They may complain of a headache, of feeling hungry. Have you ever gotten hangry, where you starting to get irritable, like right now? I know you've all got it out there. I know you all do. You're all hypoglycemic. I told you to go get something to eat. But anyway, you start feeling, and this happened to me all the time when I was on a road trip with my ex-husband. Yeah, can we pull over and get some lunch? No, let's just go another 100 miles. Okay, now I need to pee. Oh, it's okay, we'll wait till the next town. I don't know about you, but related to the food or the lack of food intake, you start getting a little bit of irritable there, and you start shaking, your hands start shaking a little bit. Yeah. So these are signs and the symptoms of hypoglycemia. And you will want to do, if in fact the patient complains of that, or you sense that, or you see that, then you'll want to confirm that diagnosis by taking a finger stick, blood glucose finger stick. Okay. So what are some of the acute complications of that? First of all, they can be mild, moderate, or severe. And so with the complications of hypoglycemia, person can start to sweat, tremor. Yeah, I just told you about that. Tachycardia, nervousness. Yeah, irritability. Yes. Hunger. Yes. Feed me. Then moderate may start to impair functions of the central nervous system. So the person may start getting a headache, may get confused, balance may start to, the person may not be steady on their feet. They may have slurred speech. It's because of my dry mouth today. It's not because of my hypoglycemia. Impaired coordination, emotional changes. People get really, really irritable. They may get drowsy. And then we can have severe. And this is where you need assistance. You no longer can go grab yourself a snack and go to the vending machine and be saved yet again by a little snack bar. Nope. You gotta, this is when you have severe hypoglycemia, the person isn't able to help themselves. They have disorientation. They may have seizures. They may be very difficult to arouse from sleep, or they may have a loss of consciousness. It's amazing to me to see the difference in someone that is severely hypoglycemic when they're non-responsive, and you give them a little bit of dextrose, or if you can get them, if they're just very lethargic and still responsive, but if you can get them to eat a little piece of bread or something, it's amazing. You wait there for 5 minutes and boom, they start coming around again, and you get them to eat a little snack and boom, in 15, 20 minutes, they're normal again. It's amazing the difference that happens. But you need to recognize the severity of the hypoglycemia and the signs and symptoms that are associated with that. Okay, so this is for the immediate treatment of the conscious patient. Because we're not going to give anybody that's unconscious anything to eat or drink. So there is an adjective that you want to pay attention to. So for immediate treatment for the conscious patient, we want to give them 15 grams of fast-acting carbs. So this is where you're going to have 2 to 4 glucose tabs, which you can buy over the counter at any pharmacy, 4 to 6 ounces of fruit juice, and again, got to have that patient, that conscious patient there. And I have to tell you, I've changed this. This is fast-acting. Notice this fast-acting because look at this is orange juice or regular soda with sugar in it. Because why we're talking about sugar, these are simple sugars here. It's going to go up, it's going to come down. but it works very quickly, and that's what we want. 6 to 10 lifesavers or 2 to 3 teaspoons of sugar or honey. So if the person doesn't resolve this, then we want to repeat this again in 15 minutes until the hypoglycemia and the signs and symptoms of it subside. So do you think you're going to want to know this slide? I think so. Put the big star there. And then after the hypoglycemic episode, they're up, they're conscious again. Remember, I told you giving them a starchy snack. You can give them cheese or crackers, or you can give them a sandwich, a protein, with ham or peanut butter, something. You want it to be longer acting, a complex carb, so that the sugar level is longer acting. If the patient is unconscious, now we're talking about non-responsive patient. Know the difference, people. You want to give 1 milligram of glucagon, either sub-Q or IM, and it takes a little bit longer for that patient to regain consciousness. Remember, I told you with dextrose, it's fast acting, and within minutes they start to respond. But with long acting or complex carbs type of things, they're going to take a little bit longer. In a hospital setting, if it's really bad, this is hypoglycemia. We may start D50 with water. D is dextrose. So if you hang a bag of D50 water, you've got to know that 50% of it's going to be dextrose and 50% of it's going to be water. And then avoid high-calorie, high-fat foods to correct the hypoglycemia. Because the fat content is going to slow the absorption of the glucose and cause that and make it longer for them to start responding. So if you overcorrect, then this can cause the cycle of hypoglycemia with hyperglycemia, hypoglycemia with hyperglycemia. Okay, so the acute complications of diabetes, insufficient hyperglycemia is insufficient insulin and stress. These are the signs and symptoms: hunger, sweating, tremors, blurred vision, headache, irritability, confusion. Okay, let me go back to that. Before I leave this, I just wanted to mention. So these are acute complications resulting in hyperglycemia. So what can cause this? And that can be, most of all, that it's been the diabetes is undiagnosed. It can be a result of illness or infection, because that will release stress hormones like your corticosteroids, which will increase your sugar levels. Or it can be due to a decreased dose of insulin. So just be aware of the complications that can occur and why they can occur for hyperglycemia, and then know what the signs and symptoms are. Okay, yeah, we'll just keep plowing. Does anybody else just think this is the longest lecture in the universe? Okay, I expected 20 yeses in the word right immediately, because it's like, oh my gosh. Okay, let's keep going. Okay, so diabetic ketoacidosis. This is, I know, in fact, oh my gosh, are you getting ready to have a pediatric sim on this? Yes, you are. So this is real important for you to understand here. Your patient is going to be in DKA, diabetic ketoacidosis. Now, this is what you need to know about that. First of all, that diabetic ketoacidosis most commonly occurs in type 1 diabetes. In fact, This is how oftentimes a person first gets diagnosed with diabetes is because they don't know they have it. They don't recognize any of the signs or symptoms, and all of a sudden they get sicker than a dog because their body has started burning fat, uh, releasing ketones into the blood, and the ketone turns the blood acidic. And I'm sorry, the blood has such a small range um, uh, for the pH. It has to be between 7.35 and 7.45. Really? Really? Because if the blood gets acidic, then it's not going to do what it's supposed to do. No, it's got a very small, very tight range on it. It's just amazing to me that I have stuck my hand into a 17-year-old's gut before. He was a football player, was driving around the corner on the highway late at night. I don't know if he was drinking or not, but he impaled himself on one of those wooden sticks on the side of the road. As he took the corner, and his car flipped and flipped and flipped and flipped him out, and he landed abdomen down on that wooden stick. Or it wasn't a stick, it helps to keep you from going over the edge. Anyway, I've had my hand into his abdomen, and he survived just fine. But you get the pH level in the blood out of that teeny tiny range of 7.35 to 7.45. You get down to 7.3, 7.29, and boom, you're out of here. It's just amazing to me. That is how amazing the human body is to me. And so we have to keep this blood in its range because the ketones are making it acidic, therefore it's not doing the job that it needs to do. So what can cause diabetic ketone acidosis? And again, a lot of times people don't know. With type 1 diabetes, remember, they have no idea that they have this. And a lot of adolescents, 13, 15 years old, come into the ER and they're in metabolic acidosis, and they are very, very sick cookies with blood sugars. Oh my gosh, look at this. My patient was admitted with a pH of 6 and a sugar of 170. I've seen blood sugars up to 1,500 before. 1,500. These people are sick, 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 sick. So the causes for this can be that they have a decreased or missed dose of insulin. Illness or infection is going to be a huge one. Huge, huge, huge cause for somebody going into diabetic ketone acidosis. Or, like I said, this is the first time they're being treated. They don't know that they have it. So usually the blood glucose levels are going to be greater than 300. But like I said, I've seen them up to 1,500 before. And the severity of the signs and symptoms for ketone acidosis is not necessarily related to the blood glucose level. So you look back over here at Kimberly's comment. She said, my patient was admitted with a pH of 6.0. Now she was alkalosis there and a blood sugar of 170. So acidosis is going to be less than 7.35. Okay. All right, so what are the clinical manifestations of DKA? First of all, it's hyperglycemia. Yeah, you're going to have these elevated, greater than 300. They are going to be dehydrated, and there's going to be a loss of electrolytes, which makes sense. Dehydration is going to have the person, because they've excreted a lot of electrolytes. Those two things always are going to go hand in hand. Electrolyte loss, low levels of electrolyte associated with dehydration, and then, of course, acidosis because of the ketones in the blood. So here's the clinical manifestations. You're going to have your polyuria, your polydipsia. The skin is going to be warm and flushed. Blurred vision, weakness, headache, tachycardic, orthostatic hypotension, GI symptoms, anorexia and nausea and vomiting, maybe some abdominal cramping. Also, when you're dehydrated, when you're severely dehydrated, you are going to have GI symptoms of nausea and vomiting, which is going to contribute to the dehydration as well. Acetone breath, and that's related to the ketones in the blood. Kussmaul respirations. Now, clear back in the respiratory lecture, we talked about Kussmaul respirations. And they're deep, they're unlabored. But what they're trying to do is, I say that they're unlabored. The fact of the matter is that they're deep, so you are retracting with that. But they're trying to blow off, what the body's trying to do is blow off the ketones there and get rid of the acidosis. And then the person may experience, depending on how acidic they are, mental status changes. They may be non-responsive. Okay, so let's go back here for a minute because I want you to relate these two. 3 main clinical features: hyperglycemia, dehydration and electrolyte loss, and acidosis. So what are we going to do? We're going to treat these things. So we go over here, and first of all, rehydration is the #1 step. And look at this massive amount that we're rehydrating. Why? Because they're dehydrated. So initially, we're going to put normal saline in, and we're going to put in 1 liter an hour for 2 to 3 hours. So you're looking at 2 to 3 hours of fluid here, of 1 liter. 2 to 3 liters of fluid we're putting in to rehydrate the person. And then after 2 to 3 hours, then we will put half normal saline, and we'll put in 200 to 500 milliliters an hour to rehydrate the patient. Now, during this phase, we have got to monitor, of course, the fluid status, because we are dumping in a lot of fluid. We got to make sure that they are peeing it out. And so we want to monitor their blood pressure, because there are going to be a significant blood pressure changes because we're putting in such a huge volume of fluid. We're going to monitor their heart rate, and we want to monitor their eyes and nose, make sure they're peeing out what we're putting in. Then we look over here at the loss of electrolytes. So what do we have to do? We have to replete or restore the electrolytes. So potassium is going to be huge. We want to especially monitor the potassium. Why? Because remember, they were dehydrated and had peed out a lot of fluid, and so their potassium levels are going to be really, really low. So what happens here is how do we infuse this potassium? How do we get potassium back into the blood again? Well, this serves a double purpose here by doing insulin administration. And this helps us because that's going to take that high level of sugar out of the blood if we administer insulin. But usually this is started in a drip form via IV. And we start it very, very slowly. But we give them insulin for 2 reasons. First of all, it's going to bring down the sugar levels. And second of all, when we get insulin, it enhances the movement of potassium back into the cells. And we want it to do that. So the thing about it is that we can infuse potassium, but we have to replace that very cautiously, because what can potassium do? It can cause arrhythmia, cardiac arrhythmias, lethal cardiac arrhythmias. So we have to infuse it very slowly. We're taking labs frequently for potassium levels. But also, we want to reverse the acidosis. So we, again, are going to do a slow, continuous infusion of insulin. And when I say slow, we're talking 5 units per hour. That is really slow. You know those little insulin syringes, and we pull up 5 units, and we can hardly see it because of the safety thing that we've got to deploy? That's all we're giving them per hour. But why? Why don't we dump? This happened all the time back in Oklahoma. We have 3 main cities in Oklahoma: Oklahoma City and Lawton and Tulsa, where I'm from. But everything else is rural. So you have these rural hospitals out there. Somebody goes in there with DKA. They've got 1,500 a blood sugar level. What do the emergency room doctors out there? They dump all this insulin, trying to bring the insulin or trying to bring the blood sugar levels down because they think that's the problem. I don't know if they're real doctors out there or not. I can't imagine why they do this. But why don't we do this? Oh, I just scrolled down and there's like 50 other comments. That would make them drop way too fast and they could die. Why would they die? Fluid shift, exactly. Woo, woo. So she shifted it. So there you go, Amy Cooper. Thing about it is that I'm staring. I'm looking at different comments. I start thinking about different comments when I'm speaking, and then I lose my place, and then I have to come back on point. Anyway, so why the fluid shift? So what happens here is that sugar pulls, the fluid shifts cause the brain to swell, and there would be a herniation. Okay, so the fluid is going to follow the sugar into the brain. Remember, the brain is only taking carbohydrates for fuel, so it's got a lot of it in there now. If we got blood sugar levels of 1,500, so the fluid is going to come into the brain. It's going to swell and cause herniation. So a brain can herniate if you give a person that has is in ketoacidosis and has too much fluid. Has too much insulin coming in, which is going to shift all that fluid and cause the brain to herniate. You can kill them. So you don't want to do it. So you start insulin very, very slowly. And you take your blood sugars every single hour, and then accordingly, you can either reduce or increase the infusion of insulin, but you have to be there. And you only do it by 1 unit. You don't do it by more than 1 unit. You always titrate by 1 unit. So then when you bring your blood sugars down to a certain level, we don't want to continue to infuse that insulin without a little bit of sugar coming up, so that there isn't going to be a wide fluctuation. So when the blood sugar levels get down to between 250 and 300 milligrams per deciliter, then we start giving them a little bit of dextrose, a little bit of sugar, to prevent a sudden drop of sugar in the blood, because we don't want that fluid shift that can cause some real problems. So maintain the insulin drip until the acidosis is corrected. Sometimes bicarb, which is your neutralizer, infusion may be infused to correct the acidosis, but we try to avoid that because it decreases levels of potassium in the blood. Okay. Now, remember, ketone acidosis is associated with type 1 diabetes because there is no insulin in the blood. The pancreas does not produce any insulin. Therefore, no glucose gets into the scales. Therefore, fat is burned and ketones are produced, and ketones get in to the blood, causing the acidity, which causes the acidosis. So with type 2 diabetics, the pancreas does produce insulin. So there's always some insulin in the blood, and so the cells are resistant to that insulin bringing the glucose in, but sometimes it does happen. But usually there is enough sugar, glucose getting into the cells that the body won't burn fat for energy. So there are no ketones. Now you have all the other problems, the same problems, the dehydration, the loss of electrolytes that you have with ketoacidosis, but you don't have the ketones, and so you don't have the acidic blood. But we're going to treat the type 2 diabetic that has the HHNS the same that we do for a type 1 diabetic that has ketoacidosis, except we don't treat the acidosis. So this is how we work with them. These people will have extremely high glucose levels, 1500 milligrams, and they will have some hyperosmolality, but they won't have any ketoacidosis or ketosis, as I said earlier. So what happens here is a person with type 2 diabetes can get sick. There's usually a precipitating event to this HHNS attack, so to speak, or episode. So they'll get pneumonia, or the person will get a stroke. They'll have stuff with stroke, CVA is the same thing. But anyway, the body is now stressed. So the blood sugars are going to get high because of the sickness. So also another thing that we can give these people is medication that can exacerbate the hyperglycemia if they have blood pressure, high blood pressure. So sometimes if we just put them on dialysis, then it can also cause a person to go into HHNS. So again, the complications are going to be blood glucose level of 600 to 1500. This is an insidious onset. It means it just can come on and just hit you, and you're going to end up with severe dehydration, hypotension, extreme thirst, excessive urine, sensory and motor impairment, seizures, hallucination, and a depressive sensorium. So how do we manage this? So we are going to rehydrate them, just like we do with DKA. We're going to restore their electrolytes, just like we did with DKA. And we are going to administer insulin. But it is not as important for type 2 diabetics that are in HHNS as the type 1 diabetic in DKA, because we don't need the insulin to reverse the acidosis. But we may administer insulin to help increase the return of potassium into the cells. It's a little bit slower process. You'll see that it may take 3 to 5 days for neurological symptoms to subside. All right, so one of the things that the patient will be educated about that goes into our final area of management for somebody with diabetes is that they are going to have to learn to manage sick days. And this is part of the education that the diabetic educationer will give to the patient newly diagnosed with diabetes, because they have to learn to recognize what's happening in their body so they can prevent complications. So when a person gets sick and stays home from school or stays home from work, you take your insulin, your oral anti-diabetic agent as usual. This is true for both type 1s, type 2s. You want to test your blood glucose and urine ketones every 3 to 4 hours. Report high glucose levels greater than 250. Or report if you have urine ketones. Why do you think we're going to check for urine ketones if our glucose level is greater than 250? That's what I said. That's what I said. That's usually when the body starts utilizing fat, is when the glucose that we do have available is not getting into the cells. So we have all this excess blood glucose in the blood, and we know that the body will start burning fat if it gets to be more than 250. It's an earlier screen. Yes, it was. We talked about that. So you may need to do supplemental doses of regular insulin because, your blood sugars are getting high. Again, we're trying to prevent these wide fluctuations in glucose levels. So remember, if you are sick and you have the flu and you're vomiting and diarrhea or fever persists, then take 8 ounces of liquids, again, because this is going to contribute to dehydration. So you can have juice, broth, or Gatorade every 1/2 to 1 hour. You just got to keep it going because you don't want to get dehydrated. And report any persistent nausea, vomiting, or diarrhea to your physician. And if you're not able to keep fluids down, then you may need to go be hospitalized to prevent DKA. You cannot treat DKA at home. You have to go to the hospital to get it treated. But at home, there's certain things that you can do because, again, you don't have the ketones in the blood. All right. Just briefly, we're going to go on to the overall complications of diabetes mellitus. And when these different areas, I tell you, tell you what is happening in the body. So you have microvascular complications. And we talked about diabetes being a precursor for coronary artery disease, myocardial infarction, cerebral vascular accidents, and peripheral vascular disease, mainly because it all relates to atherosclerosis, which originates usually with fat and high sugars in the vasculature. Now, microvascular complications occur in the eye and in the kidney. And that is why, and you can imagine, so when you think about the anatomical structures of the eyeball and the kidney, then you know that we're talking about very microscopic cardiovasculature. And so those big old glucose molecules can just, if they get down there and can't get out to where at the capillary level, then it's just those big old glucose molecules are going to just tear up those vessels. You tear up those vessels, then you're going to inhibit or occlude the supply of oxygen nutrients to those little tiny structures. And all of a sudden, you're going to have an inflammation and ischemia and death occur. So for uncontrolled diabetes, a lot of times you'll see diabetic retinopathy or blindness. And also another devastating complication would be nephropathy, where the person's kidneys begin to fail. Also, there can be another complication of diabetes mellitus is your diabetic neuropathies. So this is your foot and leg problems. And this is where and why we discussed foot problems and wearing good exercise footwear and to check our feet afterwards, because when we're getting to those very distal parts of the lower extremities, again, this is the most distal part where the blood is needed to supply nutrients to the vasculature. And if it's not there, you're going to have those nerves affected and neuropathy will develop. And you will see that a lack of circulation down there is going to cause ischemia, which is going to cause inflation, which can cause gangrene. So, and there can also be an autonomic neuropathy where there's no control anymore over, so what's going to be affected is those functions of the body that we cannot voluntarily control. So your blood pressure, your temperature, your GI tract, GU tract. Sometimes, these are the tracts, these are the symptoms, not always just the bladder sphincter. Okay, so again, you can see down here that the lack of circulation has resulted in a lack of circulation and necrosis to the most distal portion. And the sad thing about necrosis is that that tissue releases toxins, which feeds off of live tissue. So necrosis isn't going to stay here unless you amputate this. And to amputate it up here, because this tissue is going to feed off of this tissue. So a week from now, you may find this area black. Another 2 weeks from now, you may find this area black. We have to amputate it to stop the toxins eating off the live tissue. And there was a gal that I taught in Oklahoma that she's in a nursing home. She had diabetes. She lost her foot, and then she lost her below the knee, and then she lost her thigh, and it moved up into, the necrosis had moved up into her torso, and thankfully she died. But it's an insidious, horrible, horrible thing to happen when your feet start getting this bad due to a lack of circulation. And the lack of circulation is in large part due to the huge glucose molecules that are tearing up those little blood vessels, but also that infection feeds off of glucose and sugar. They love that sugar. Oh my gosh. We're done. We're done. I'm so happy for us all. So happy for us all. I'm sending you all love. Kisses till tomorrow, because tomorrow, look at that. Already, aren't you excited about the hypothyroidism? I personally am. But I'm glad that we got through this, and I'm wishing you a good day. And I will do a review on this on Wednesday. And peace out, people. I'm loving ya. Truly am. See you. Bye.